Dr. Al-Hafez. Just hit continue. Okay, great. Thank you for that wonderful introduction, Dr. Al-Hafez. We, in the last couple of division meetings, what sparked my interest in doing warfarin and pregnancy, we have a patient that was seen as a preconception consult with a mechanical valve. And we had great discussions regarding the optimal anticoagulation regimen for this patient once she becomes pregnant. And so I thought it would be great to educate myself and review the evidence. And so the outline of our talk is we'll talk about the mechanism of action of warfarin, the risks in pregnancy, specifically the management and mechanical valves, antepartum, and both pertaining to delivery and anesthesia, and then breastfeeding. So the mechanism of action of warfarin is a vitamin K antagonist. The liver synthesizes coagulation factors as well as protein C and S, and these require the presence and activation of vitamin K. Vitamin K itself is activated by a vitamin K epoxide reductase complex 1 or VCORC1, and warfarin acts by inhibiting the subunit 1 of this complex, therefore depleting functional vitamin K reserves and reducing synthesis of active clotting factors. So the risks in pregnancy, because warfarin does, as we all know, does cross the placenta, is associated with miscarriage, around 30% of the time, embryopathy around 5 to 10%, IUFD 10%, and fetal bleeding around less than 10% of the time. And when we discuss fetal bleeding, this mostly is in reference to fetal intracranial hemorrhage. And so the embryopathy part of it, this is mostly associated with exposure in the first trimester. The most common embryopathy abnormalities affect the bone and cartilage, resulting in something called chondromalacia punctata, which is essentially shortened bones with punctations and stippled epiphyses, and nasal and midface limb nasal, midface, and limb hypoplasia. And you can see in this picture on the right-hand side with the profile causing nasal hypoplasia. This may be related to the drug's interference with the post-translational modification of calcium-binding proteins that are important for development of bony structures. This is some X-ray imaging showing the chondromalacia punctata, and all of these different arrows are illustrating the extensive punctate calcifications of the epiphyses of the femoral heads, which is classic. Other kind of less well-documented associations with the warfarin embryopathy are CNS abnormalities, such as optic atrophy, microcephaly, mental retardation, hypotonia, and these can really occur at any stage during the pregnancy, not just from exposure in the first trimester. And this complication may be related to fetal anticoagulation bleeding to cerebral microhemorrhages in the neuronal tissue. And so the risks of warfarin in pregnancy, literature has found that it's gestational age dependent, which makes sense because we all know that organogenesis is in the first trimester and the highest risk is at 6 to 12 weeks of gestation. But as I just mentioned, toxicity before or after this period is still possible. There's an observational cohort of 408 pregnancies with exposure. And they found that cessation before 5 weeks of gestation resulted in no increased risk of birth defects. But if the vitamin K antagonist or warfarin was continued after 7 weeks, the risk of birth defects was 10.8% compared to 2.3% in unexposed pregnancies. And then they also found the risk of miscarriage was also increased 38% versus 17% in the unexposed pregnancies. And the hazard ratio of miscarriage was 1.12 for every additional week of exposure. There was also a systematic review that looked at the composite fetal risk and the components of the composite was miscarriage, death, and congenital abnormalities of warfarin used throughout the whole pregnancy, and found that, or warfarin compared to other anticoagulants, and found that 39% risk of composite fetal adverse outcomes with warfarin alone compared to 13% with low molecular weight heparin alone, and 23% with sequential anticoagulation. So low molecular weight heparin in the first trimester and warfarin second and third trimester. And you can see, because you're using warfarin throughout the pregnancy, even in the second and third trimester, it's still a higher risk than using low molecular weight heparin alone. And so the literature has also shown that not only is it gestational age dependent, but it's also dose dependent. Doses less than 5 milligrams per day appear to provide a higher margin of safety, but teratogenicity at these doses has still been reported. This is a systematic review of 46 studies, the largest one that I could find, assessing the effect of warfarin in pregnancy. And you can see warfarin doses less than 5 compared to greater than 5, the live birth rate significantly higher with lower doses, 83.6% versus 43.9%. And the fetal adverse outcomes also significantly lower, 2% versus 12%. And so, because of these risks, warfarin is generally avoided in pregnancy due to the known effects. But what is really the optimal management for women that are at exceptionally high risk of thromboembolic events, such as those with mechanical valves? We know that women with mechanical valves require uninterrupted therapeutic anticoagulation with frequent monitoring to prevent valve thrombosis and these events. Outside of pregnancy, warfarin is the most effective anticoagulant to prevent these thrombotic complications. And in pregnancy, there's an absence of adequate prospective controlled trials looking at the different maternal and fetal risks associated with the various anticoagulants. And so the optimal anticoagulant regimen is still considered uncertain, but we have to weigh the risks and benefits of the different anticoagulation therapies in order to find the optimal regimen. And so the potential treatments that we can consider for women with mechanical valves is either warfarin throughout the whole pregnancy, heparin in the first trimester, and then switching to warfarin second and third trimester, or heparin throughout the pregnancy, and this being low molecular weight heparin or unfractionated heparin. And so again, there's no randomized control trials in this, but we have to do our best and review the best evidence-based literature. And so this is, again, from that large, very excellent and thorough systematic review, comparing maternal and fetal outcomes of 2,468 pregnancies on different anticoagulation regimens. And again, you can see here maternal mortality, thromboembolism, live birth rate, and then fetal adverse effects. That's what they're looking at. And the use of warfarin throughout the pregnancy was associated with the lowest pooled proportions of maternal mortality and thromboembolic events, followed by sequential treatment, and then low molecular weight heparin, respectively. In contrast, actually, unfractionated heparin had higher maternal mortality and thromboembolic events. And then in terms of live birth rate and fetal adverse events, vitamin K had the lowest live birth rate, 64% compared to the others, and a higher risk of adverse events. In this table, actually, not only did unfractionated heparin have higher maternal mortality and thromboembolism, but also had low live birth rates and highest risk of adverse events. And in the study, they explain it that this is really associated with maternal illness, and that the fetal and neonatal adverse events is related to prematurity, because these were much sicker moms going into preterm labor, higher risk of mortality and thromboembolic events. And so because of this, unfractionated heparin really is not one of the optimal, regimens that's, or one of the choices that we should use when we're considering anticoagulation in mechanical valves. So the authors also thought to do a sensitivity or a subgroup analysis to study the outcomes by INR to see if that was a better guide, rather than just, looking at doses of warfarin higher than or less than 5 milligrams per day. And so they had INR targets of 2.5 to 3.5, which is usually the standard when we're using warfarin. Stricter targets 1.5 to 2.5. Also looking at studies that stratified the INR based on risk factors. And so different women getting different targets based on their age, BMI, which valve was mechanical, number of mechanical valves, and then the studies that looked at warfarin use regardless of INR target. And they didn't find really much difference between maternal mortality and thromboembolism. But they did see that here with stricter INR targets, there were higher live birth rates, but higher risk of fetal adverse events. And so the safety and use of lower or higher or stratified INR targets really hasn't been determined yet at this point. So ultimately, based on review of the literature, the American College of Cardiology and the American Heart Association put out guidelines, and these are the latest from 2020. This takes into account balancing the risk of developing thromboembolic complications during pregnancy against the risk of maternal and fetal complications of anticoagulation. And it also takes into account that the patient is, reliable and able to take the medication, undergo the frequent monitoring. And so after counseling, if you look at the warfarin dose, if it's greater than 5, if it's less than 5 milligrams per day, then the recommendation is to continue warfarin for all 3 trimesters. And yellow is what's recommended. Orange is the alternative. If the patient after counseling does not desire to take warfarin because of the associated risks, then you can use dose-adjusted low molecular weight heparin for the first trimester, followed by warfarin for the second and third trimesters. If the warfarin dose is greater than 5 and they are able to undergo frequent monitoring on the dose-adjusted low molecular weight heparin, then the recommendation is to use that for the first trimester, followed by warfarin for the second and third trimesters. Again, if the patient is unwilling to do so because of the associated risks, then you can use a dose-adjusted low molecular weight heparin for all 3 trimesters. In regions, and so for the low molecular weight heparin, they really should undergo anti-10 levels weekly, just to make sure that the dose is correct. Fixed dosing is never appropriate because it's associated with a high maternal morbidity and mortality. And so in situations where low molecular weight heparin is unavailable or they're not able to monitor the anti-10 levels, continuous infusion of unfractionated heparin can be used as an alternative, but this is really a last resort because and so what they do is they give them continuous infusion of unfractionated heparin and make sure that the PTT is 2 times the control. But there are several disadvantages, obviously, to having someone on a continuous infusion, and specifically with unfractionated heparin. Women are at greater risk for line infections, osteoporosis, heparin-induced thrombocytopenia. And so unfractionated heparin should really be reserved for situations where dose-adjusted low molecular weight heparin is not feasible. They did mention that intermittent subcutaneous injection of unfractionated heparin is not an acceptable alternative because it's associated with unacceptable rates of valve thrombosis and maternal mortality. And we saw those increased numbers in the previous table from the systematic review. This part pertains to the delivery, and we'll get to that in a second. And so in order to have thorough counseling for the patient, in order to really decide what is best for her, is that patient needs to understand that there are still fetal risks with warfarin doses, even less than 5. It does not eliminate those risks. And although the teratogenicity of warfarin is highest during the first trimester, there is still a risk of pregnancy loss or hemorrhage when warfarin is taken during the second and third trimesters. Now, when it comes to delivery, because warfarin results in an anticoagulated fetus, there's a high risk of fetal intracranial hemorrhage if vaginal delivery is attempted in a woman who is fully anticoagulated with warfarin. This risk is thought to be greatest during and immediately after delivery due to the immaturity of fetal enzyme systems and the relatively low concentration of vitamin K, rendering the fetus more sensitive than the mom to the anticoagulation effects. And importantly, the fetal coagulation factor levels do not correlate with maternal levels. And so if you try to give the mom FFP, it doesn't really reliably reverse the fetal anticoagulation. And so the same two societies, the American College of Cardiology and the American Heart Association, did put out guidelines for delivery. And the recommendation is that at approximately 36 weeks, or at least 7 days before planned induction of labor or cesarean delivery, whichever is earlier, warfarin should be switched to dose-adjusted low molecular weight heparin, administered at least twice daily, and checking anti-10 levels. And then at least 36 hours before delivery, switch to continuous IV unfractionated heparin and monitor the PTT. They put this recommendation out, and then 46 hours before delivery, stop the IV heparin. And this is really to facilitate receiving neuraxial anesthesia and minimize the risk of bleeding during delivery. Now, alternatively, I know that we've, in our own practice, just outside of mechanical valves in general for anticoagulation, we've kind of strayed away from switching patients at 36 weeks to unfractionated heparin, keeping them on their low molecular weight heparin if we think that there's a low likelihood of them going into spontaneous labor on their own, or we have a scheduled delivery plan. And so alternatively to switching to IV unfractionated heparin 36 hours before, you can use intermittent prophylactic doses of low molecular weight heparin. So switching them to a prophylactic, for example, 40 milligrams daily, initially, essentially the night before, and that the neuraxial anesthesia can be delayed for at least 12 hours after the last dose of the prophylactic low molecular weight heparin. And so on rare occasions, urgent delivery is indicated when a woman with a mechanical valve is still receiving therapeutic anticoagulation. And management of this becomes a little bit more complicated because we're balancing the risk of life-threatening maternal hemorrhage against the potentially catastrophic risk of thromboembolism or valve thrombosis if the anticoagulation is reversed too quickly, and essentially the fetal consequences of not performing an urgent delivery. And so because the fetus is also therapeutically anticoagulated, the American Heart Association and College of Cardiology do recommend a cesarean delivery to reduce the risk of fetal trauma and hemorrhage. But before moving towards a C-section, there should be some reversal of anticoagulation to prevent the risk of postpartum hemorrhage. And so they recommend that warfarin obviously be stopped, and 4-factor prothrombin complex concentrate should be administered to a target of INR of 2. If this prothrombin concentrate is unavailable, then FFP can be administered. But they mentioned that FFP administration is not generally sufficient in an emergency situation, given the amount of time required to thaw the FFP and administer it. And so it's not really recommended. PCC is faster to obtain and to administer. In addition, small doses of oral or IV vitamin K will reverse the maternal INR in approximately 6 hours or more. So they recommend giving this even if you're moving to the OR emergently, because it can help decrease the risk of obviously postpartum hemorrhage. However, these oral or IV vitamin K doses to the mom will not effectively or help fully reverse the effects in the fetus. And so routinely these babies are given vitamin K and FFP after delivery. In terms of, I just wanted to put a slide on neuraxial anesthesia just for our learning. Spinal and epidural anesthesia may be used in patients who have discontinued warfarin, ideally at least 5 days earlier. That's per the Society of Regional Anesthesia. Or in those who have had their warfarin effectively, appropriately reversed at the time of neuraxial needle or catheter insertion. And what they consider as reversed is if the coagulation status is normal as indicated by normal coags, or the INR is less than 1.2. And then lastly, just quickly about breastfeeding, since I'm sure we would get this question from multiple people, breastfeeding is considered safe because warfarin has not been shown to be present in breast milk, and this is supported by multiple societies, including ACOG, the American Society of Hematology, and the American College of Chest Physicians, in case anybody asks. It's supported by all of these societies.
Boards.
That's it. Thank you, guys.
Beautiful, Leen.
Thank you.
thank you so much for going over the great, very pertinent evidence and recent up-to-date guidelines. Did you have was there a patient with mechanical valve that you were recently caring for that that brought this up?
Yes, there was a patient that was presented a couple weeks ago. I believe it was a preconception consult. She has a mechanical valve, and we were discussing what to do when she becomes pregnant. And I believe her dose was more than 5 milligrams per day. But Laura, correct me if I'm wrong. I believe it was more than 5. So I think the last discussion that we had was switching her to low molecular weight heparin in the first trimester, and then warfarin second and third. But
she's on 5 and 7.5 alternating every day.
So more than 5.
The biggest challenge for her is that she's had multiple thrombotic events of her valve while supposedly on anticoagulation that are presumed due to non-compliance, and the patient is just she understands, she can verbalize the risks of not taking anticoagulation, but she doesn't seem to internalize them or appreciate the actual risk to her own life. And she's a little bit cavalier about her anticoagulation. She very much wants to become pregnant and says things like, well, anybody could die in a pregnancy at any time, and maybe I'll just stop everything and just not do any of the monitoring. So I think she's just challenging in a lot of ways. One, she has a higher dose of her Coumadin, but 2, she
is not compliant. I mean, the guidelines, I mean, they reiterated this multiple times, that if someone is not able to, come in for the weekly monitoring of anti-10 levels on the adjusted dose of low molecular weight heparin, to keep them on Coumadin, because the risks of maternal mortality are just too high if they're not being able to get the appropriate dose of Lovenox.
And we did talk to her about potentially continuing the Coumadin because of the risk to her. She's planning IVF, and so we are also sending her to the cardio-obstetrics clinic. I think another thing that's a little bit challenging is that whoever the cardiologist is that she saw prior to, who has been following her, said under no circumstances should you get pregnant, and was really unsupportive. And I think that just made her feel even more sort of indignant and like, well, you can't tell me I can't get pregnant. If I decide to do this, I'm going to do it.
Yeah.
And I think if we can be supportive and help her make a decision that she feels is right for her, hopefully that will have a better outcome. Her cardiologist did say, just for the record, that she could go on Lovenox.
Thank you. It's Laura, appreciate sharing that. I think it's striking, as you shared, Leen, that the risk for birth defects, even on warfarin throughout pregnancy, is under 11%. And that's very different than the lay public and even non-OB, non-MFM providers' perception. People think, the advice under no circumstances or warfarin always causes birth defects.
Right.
It just reminds me of the saying when people talk about things crossing the placenta, maternal death crosses the placenta too.
Right.
Very bad for babies, for fetuses as well. So anything that Leen, that you'd recommend differently? It sounds like Laura, it's very much kind of what she's heard before for that patient, and trying to support her, but in a way that'll be as safe as possible for her and pregnancy in the future.
I think that if she, and I'm sure the counseling was excellent, both by cardiology and our team, but if she is willing to come in weekly to monitor the anti-10 levels, then I would also do low molecular weight heparin in the first trimester and then switch to warfarin second and third trimester, just because of how high her Coumadin dose is.
So, yeah. Jason, did you want to say something?
I'm wondering if there's a way to influence her kind of, Laura, as you will describe it, her kind of resistance to this cardiologist saying under no circumstances, and her saying, well, I'll show you, and say, well, hey, how can we empower you? it's by coming in for these weekly
Right.
values, or hey, you're not willing to do these weekly values, here's a different way to do it, maybe on warfarin throughout. How can we work with you? And yeah, we want to quote, prove you right to have a healthy pregnancy. But here it's going to take some teamwork together to do that. And I think the cardio clinic is a great way to do that, working MFM and cardiology side by side. Sorry to interrupt you.
No, this is a great presentation, and you practice in a first world country. I come from a third world country, so I was in medical school very early, like 30 years ago, and I did my residency back home, and limited resources. So when you have a young patient who needed a heart valve replacement, they immediately put mechanical valve for them, because if you put a tissue valve at that time, you're going to have to change it every 10 to 15 years, and there's no resources for these patients to have repetitive open heart surgeries. So we had this Wednesday cardiology clinic where we will have 5 to 10 patients who have mechanical heart valves. I cannot tell you how many I've listened to, medical school and then residency. So we had a large number of patients, and I don't think there was love knocks in the early 90s, unfortunately. So we had to deal with warfarin alone, and there was heparin. I think love knocks came maybe mid 90s or late 90s when love knocks came. And the big lesson here, which Leen mentioned, is be careful, because you can have a thrombosis of that mechanical valve. And if this does happen, the patient may die. And we've had cases like that at my old institution in the 90s. And this is when the literature started to say, we really have to be so much careful with anticoagulation with these patients for the thrombosis for the valve. Now, Leen, you mentioned anti-10A level. This is not something that the fellows here do, so I have to make sure you're well educated. I remember like maybe 3 weeks ago, I saw someone and her anti-10A level was 0. And the question is, wow. So I told them she's not taking her love knocks, right? So when anti-10A level is 0, it means the patient is not taking her therapy. And 0.5 is on the lower limit. So these are sub numbers that you have to remember, like your PTT. What's your normal PT? So an anti-10A level 0.5 to 0.8 or to 1 is considered like in the prophylactic range. More than 1 to 1.5, this is when it is usually considered in the therapeutic range. So these are numbers it's nice to know when you're in the office. You can probably read about it and educate yourself now. This way, you're not limited in your time to know about this. And the final thing, which is really important, is Zubsha here? Zubsha is not here, okay. But basically, you cannot forget your pharmacogenomics. And I'm going to share with you something very important. I remember I was covering the pediatric genetics beeper a few years ago. And this was my one of my exposures for it. I'm contacting you because I need you to do the pharmacogenomics for warfarin for a child. I'm like, what? Why? Because they were worried that the baby had a bleeding disorder and they didn't want the baby to bleed. So I had to do, and at that time, certainly I had a lecture, which I'm going to share with you. And then let me see if you see it. So I'm going to go to the beginning of this lecture. The title is basically pharmacogenomics. I spent 20 hours twice or 3 times basically to study this lecture. And basically there is, this is from years ago, I pulled it up just to share with you here. So basically for many medications that we use it like Tylenol, correct? We don't think about the pharmacogenomics, but basically there's many medications that their metabolism is really affected by our own genomics. And if you look here, the warfarin is affected by these two, CYP2C9 and VKORC1. And if you go throughout this lecture, basically there's many medications that we use pretty often, sometimes on a daily basis. I'm just coming down. I hope I'm not making you bored, but basically for this slide, for example, it defines to you, you can be a normal metabolizer, you can be a reduced or intermediate metabolizer. You could be a poor, or you can also be an ultra-rapid metabolizer. And that is why sometimes you can see side effects from all of these medications. So I want to go to the one that says, for example, you look at Prozac, you look at Warfarin, right? So this have their own hallmark codeine, which we used to use more often than now. And then probably I'm going to go fast to go to page 21 to show you the warfarin one. Plavix, so many patients take Plavix, and it can cause complications, either underdosing or overdosing. And so if you go to this page here, is it this one, warfarin? Here you go. So there's almost 40% variability in the drug response between individuals with how warfarin is metabolized in our own system, basically. And the thing is here, nobody wants to do pharmacogenomics. There are very few people who understand pharmacogenomics. Maybe you can have one person who can do this as a lifetime career. Certainly, there are labs that do gene panels for pharmacogenomics. And basically, in the ideal world, you would want to do it before you start a medication for patients. But is it done? And the answer to that is a no. And actually, there's also specific pharmacogenomics for Lovenox and for heparin also. So I just wanted to share this with you. I feel bad my genetic counseling students were not here to see this, but I hope I opened the door for something new for all of you. So.
Thank you, Huda. Thank you, Leen.
Yeah, thank you. So I'll stop sharing now here. So fourth year, a medical student who has been working with our division for a long time. She's done lots of research with Dr. Baxter. She's done lots of research with me, with Dr. Oliver. And really, it's like sunshine when you see Julie, like the room brightens up when she walks in. So thanks, Julie, for educating us about achalasia and the successful pregnancy that this patient had.
And Rups, Huda, if I get a minute, I have a case I would love to run by the group and get some feedback on how to best manage her. You let me know when it's a good time.
Sure. Yeah.
Okay, can you guys see my slides? Yeah, okay. So hi, thank you, Dr. Al-Quatli, for the introduction. My name is Julie Gomez. I'm a current sub-I on the inpatient team. Thank you for letting us talk today, myself and Vaishali. I'll be speaking about achalasia and pregnancy. I'll go through some background, clinical manifestations, diagnosis, management, and outcomes in pregnancy. To get started, some background, achalasia in the general population has an incidence of 1 in every 100,000 people. Men and women are affected equally. There is a bimodal distribution in the incidence occurrence by age. So typically the first peak is before 30 years, and then after 60 years of age is when patients typically present. The pathophysiology is thought to be a degeneration of the smooth muscle ganglion cells in Auerbach's plexus in the esophagus. The etiology is typically unknown. There are certain medical conditions that predispose patients to having achalasia. Just to name a few, would be sarcoid, Sjogren's, and Chagas disease. There are others as well. There's thought to be an autoimmune component to it, potentially an inflammatory component that destroys the ganglion cells as well. And potentially there are genetic predispositions that are being studied at this time. Clinical manifestations in both the general population and pregnant patients are similar. They typically present with difficulty swallowing, dysphagia. It's typically progressive, so it starts out with solids and then progresses to liquids. They have regurgitation, they have reflux, recurrent vomiting, and weight loss. And so, as many of you know, a lot of these symptoms overlap with early pregnancy. And there have been reports of achalasia being missed in early pregnancy due to attributing the symptoms to early pregnancy. So moving on to diagnosis, manometry is the gold standard both in pregnant patients and non-pregnant patients. It's thought to be safe in pregnancy. There was actually a study done in 1978 published in AJOG that looked at the difference in tone in pregnant patients compared to non-pregnant patients. So it's relatively thought to be safe in pregnancy. To go over manometry, because I will be showing a few images in the next slide, as you can see here, time is on the x-axis and the length of the esophagus is on the y-axis. You can see there's increased pressure at the upper esophageal sphincter and the lower esophageal sphincter. This is a normal patient's esophagus. So you can see the intensity of the color indicates the pressure in the esophagus. So the blues and the lighter colors are typically thought to be low pressure, and then the reds or the more intense colors are indicative of higher pressures. So to go through this image, the blue here is where a patient is swallowing, so the upper esophageal sphincter is opening, and then you have normal peristalsis of the esophagus, and then the opening of the lower esophageal sphincter. This is important when we get to the following images in the next slide. Barium esophagram is another way to diagnose achalasia, and it's considered, it can be done in pregnancy. It does require radiation. ACOG's committee opinion on diagnostic imaging that requires radiation in pregnancy is that if it's needed for diagnosis, they don't recommend withholding the procedure. And there are ways to limit fetal exposure to radiation, such as shielding. Endoscopy is also used and also considered to be safe in pregnancy. Typically, this is done to rule out pseudoachalasia, which is caused by mechanical obstruction of the esophagus. And it's important to rule that out because management would be different. So there are 3 types of achalasia. This is shown by the Chicago classification. So as you can see for type 1, this is classic achalasia. It's characterized by low tone in the esophagus and an inability to fully open the lower esophageal or fully relax the lower esophageal sphincter. You may have heard of the bird's beak sign on barium swallows. You can see here, which is the classic sign for type 1 achalasia. Type 2 achalasia is actually the most common type of achalasia. It's characterized by increased pressure in the esophagus and an inability to fully relax the lower esophageal sphincter. And then this is what a type 2 would look like on barium swallow as well. Type 3, as you can see here, is a spasming of the esophagus. You can see the patient is swallowing here, and there's an increase in tone in the entire esophagus, and then increasing following as well without a secondary swallow. Characteristically seen on barium swallow is a corkscrew sign for type 3 achalasia. When talking about severity of symptoms, the Eckert scoring is used. It's a score from 0 to 12, 12 being the most severe symptoms. There are 4 categories, so dysphagia, regurgitation, retrosternal pain, and weight loss. Patients are given a score of 0 to 3 in each category, depending on the frequency of their symptoms and how much weight they have lost in kilograms. So management of patients with achalasia, specifically in pregnancy, goals are to continue pregnancy if that's the goal for the patient, and most importantly, provide nutrients for the patient if they're having trouble keeping food down. Symptomatic support, if patients are nauseous, you can give Zofran, you can give different medications that help with peristalsis in the esophagus. To name a few, sildenafil is a category C in pregnancy, but it has been used as medical management of achalasia, depending on the risks and benefits of the patient and discussion with the patient care team. This image here shows a few different supportive managements as well. Patients can receive TPN, which has the benefit of providing nutrition throughout the pregnancy without putting any contents into the stomach. Other methods that can be used would be an NG tube. However, NG tubes do carry a risk of regurgitation and aspiration because you are putting contents into the stomach. These risks can be limited if you use an NJ tube, which goes all the way to the jejunum, and that's thought to prevent the risk of reflux and aspiration as well. There have been case reports of using PEG tubes and G tubes during pregnancy in order to provide nutrition as well. However, the patients do have to undergo a surgical procedure for placement, and that's not ideal as well. So there are a few other management options. There are endoscopic and surgical options. To name a few, Botox injection, which is done endoscopically, can be used in pregnancy and actually has been reported to have good outcomes. However, in non-pregnant patients, it's typically not recommended. It's a short-acting kind of symptomatic relief, but it does not cure the problem of achalasia. A self-expanding metal stent and pneumatic dilation are both used to hold the lower esophageal sphincter open so food can pass into the stomach. These have been performed in pregnancy as well and have varied outcomes we can talk about in a second. Per-oral endoscopic myotomy, or POEM procedure, you'll hear me refer it to in the future, has not been looked at in pregnancy thus far. And there is one case of a laparoscopic Heller myotomy that was done in pregnancy, and it resulted in a spontaneous vaginal delivery at term. So outcomes, I kind of mentioned them before. They really vary with patient. They vary with gestation at time of diagnosis or treatment. But to name a few, for supportive treatment, I think the earliest case that was reported was in 1932. And the result of the pregnancy, there was no treatment at all, was an IUFD. So there was fetal demise. For some of the supportive management, excuse me, they have been shown to have varied outcomes. So some end in preterm delivery, some are, end in term delivery, and some end in C-section or termination, depending on the goals of the pregnancy. Endoscopic treatment, again, there is a wide array. They vary from spontaneous vaginal deliveries at term to preterm. Again, it all depends on the patient case. And then the surgical treatment, the laparoscopic Heller myotomy that I mentioned, did end in a term delivery. To move on to our case, this is from a few months ago. A lot of you are familiar with the case. We had a 37-year-old G3P1011 who had a history of achalasia. She had Heller myotomy in 2012 and was symptomatic, so it was considered a failed Heller myotomy. Excuse me. So she was planning to undergo a POEM procedure prior to conception and ended up conceiving before getting the POEM procedure. So a discussion was had with MFM and GI and the patient strongly desired continuing with the POEM procedure despite there not being any evidence or literature of case reports of POEM in pregnancy. So the patient did end up undergoing a POEM procedure at 18 weeks and 6 days, which was uncomplicated. To give you some background on her symptoms, she presented with dysphagia, recurrent vomiting, and weight loss in the first trimester. Her Eckert score was actually an 11 out of 12 prior to the POEM procedure. Following the POEM procedure and throughout the rest of her pregnancy, she did have some symptoms of vomiting and regurgitation. However, they were not nearly as severe. At 37 weeks and 0 days, she underwent a repeat C-section and had a healthy baby girl at 5 pounds. And following her delivery with follow-up with GI, she did not report any symptoms of dysphagia, vomiting, or regurgitation or reflux as well. So it was considered to be a successful procedure and successful pregnancy outcome. And this was the first case that we had known of a POEM in pregnancy. However, 2 weeks ago, there was a case report published of a POEM procedure done in pregnancy. And this was done in Russia. I believe it was the World Journal of Gastrointestinal Endoscopy. And they reported a similar case. Patient had achalasia, was planning to undergo POEM, and then was incidentally found to be pregnant on pre-op preparation. The patient ended up having the POEM procedure at 16 weeks. They did not report the outcomes of the pregnancy, but the most updated report of the pregnancy was that at 29 weeks, she did not have any adverse fetal outcomes or evidence on ultrasound. These are my references. I would just like to thank you all for listening. I'd like to thank Laura Felder for helping me with this case.
Julie, that was awesome. and so informative. Are you thinking about writing this case up so that there's now 2 published cases?
Yes, so the plan was to write this up. I was also planning to do a systematic review of poem or achalasia in pregnancy. There was a recent review published in January of 2021. So I'm definitely going to write up the case. I'm just not sure how far we'll go into the review part of it.
Yeah, that's great.
Thank you.
How many weeks is she now?
She delivered.
Delivered, so you could scoop that one who's 29 weeks in Russia.
Oh, the 29 weeker, I don't have any follow-up. It was published 2 weeks ago.
What I'm saying is my guess is they've probably delivered her and so may be able to get follow-up and may be able to work together with them to get the completed pregnancies for both.
Yeah, that's a great idea. Thank you. All right, I will stop sharing my screen. Thank you, guys.
That's great. And I think Vaishali is going to present today. Hi. Hey, Vaishali.
Hi.
So we're going to introduce our co-star, 4th-year medical student who did an amazing energetic rotation with us also the last 4 weeks. Vaishali also does a huge amount of research with many of us here. She's working with Dr. Angaita, Dr. Roman, and myself on IUGR chart review also. And Vaishali, we look forward for your presentation.
Thank you, Dr. Al-Hafez. Okay, can everyone see that? Great. Thank you for that introduction, Dr. Al-Hafez. You are the sweetest. My name is Vaishali. I'm another one of the medical students on service this month. Thank you for letting us present today. So today I'm going to be talking about uterine prolapse in pregnancy. This is inspired by a case we had a couple weeks ago. I'm going to be first talking about kind of the background of uterine prolapse in pregnancy, talk about a little bit of the management that I gathered from kind of limited research that does exist on this topic. And then I'm going to be talking a little bit about the case and briefly about the complications that we encountered as well. So to start with a little bit of background, so for pelvic organ prolapse in general, nearly 1/2 of women between the ages of 50 to 79 have some degree of uterine or vaginal vault prolapse or some other form of pelvic organ prolapse in their lifetime. Uterine prolapse in pregnancy for the first time is extremely rare, occurring 1 in every 10 to 15,000 deliveries. Most cases that have been reported were before 1970, likely due to the higher rates of parity before 1970 and the higher rates of C-section now with decreased rates of parity. Before 1940, there were 250 cases of uterine prolapse reported in pregnancy, a relatively higher number of cases in developing countries, likely due to a multitude of factors, including inadequate access to obstetric care and nutrition. And then, interestingly, uterovaginal prolapse is more common amongst white and Hispanic women compared to women of African or Asian descent as well. In that couple of reports that I found that in, explained by the genetic differences in pelvic floor makeup. So just to touch a little bit on etiology of pelvic floor prolapse to give a little bit of a background. So weakening of the pelvic floor connective tissue and collagen can eventually cause the pelvic organs to prolapse through the vaginal walls and pelvic floor. There are a lot of predisposing non-modifiable risk factors like race and gender. And additionally, there are other risk factors that for which intervention or prevention could be possible. Things like constipation, smoking, obesity, multiparity, malnutrition. A lot of these risk factors cause stretching of the muscle fibers and tissue, or they can cause increased intra-abdominal pressure, which together can increase the risk of pelvic organ prolapse. To touch a little bit on how pelvic organ prolapse can present in pregnancy, it can first present as a pre-existing condition, or it can present acutely in pregnancy. Those cases that present before pregnancy are less common. They often resolve during pregnancy and may recur after delivery. This type of prolapse is most frequently caused by a history of trauma to the pelvic floor or congenital disorders that can cause weakened pelvic floor support. And then acute onset in pregnancy is more common based on the literature that is out there. Usually that I've seen, it's firstly noted in the 3rd trimester, often disappears after labor and delivery. So the prolapse developing in pregnancy is more likely due to the physiological changes that happen in pregnancy, leading to weakening of the pelvic organ support and uterine relaxation, like increased levels of cortisol and progesterone. Damage to the genitourinary system from repeated pregnancies, repeated bouts of labor is also a very important predisposing risk factor for pelvic organ prolapse. And this can explain why prolapse almost always recurs or persists in patients with pre-existing prolapse, but can spontaneously resolve for patients that acutely present with prolapse in pregnancy. And in some of the literature can also explain why possible C-section can have a possible protective effect on patients that present acutely in pregnancy with prolapse compared to those that present before with prolapse. So now I'm going to just talk a little bit about degrees of prolapse and the stages. This is more from my own learning. So first degree prolapse, the organs have only slipped down slightly. The cervix is still in the vagina. Second degree prolapse, the organs have slipped down to the level of the vaginal opening. The cervix is still outside of the vulva. And then third degree prolapse is when the vagina or uterus has dropped down so much that up to 1 centimeter can be bulging out of the vaginal opening. And this is complete prolapse. And then I did see there are a couple resources that do explain a fourth degree prolapse with more than 1 centimeter, but most things I saw explain the 3 stages. So now I'm going to talk a little bit about how prolapse can cause increased risk of complications, antepartum, intrapartum, and postpartum based on the literature. So like I said, prolapse in pregnancy is exceedingly rare. It can cause significant complications during pregnancy and labor for both mom and baby. The literature so far describes that the mortality rate has decreased in the past few decades. In 1941, the rate was 22% based on a couple reports that exist. Since then, there have been very few perinatal deaths, mostly in developing countries. So most of the complications that have been described range from minor lacerations to more severe complications like bacteremia, rupture, and sepsis. So antenatally, it's associated with increased risk of abortions and increased risk of preterm labor. Intrapartum complications include things like early rupture, prolonged labor if the cervix is not dilating appropriately or if there's any sort of obstruction. Cervical dystocia is also possible due to multiple mechanisms, if there's early cervical dilation outside of the introitus or any cervical edema. And then lacerations are very commonly described. I saw lacerations as a complication in almost every case report as well. There were 2 case reports I saw with reports of uterine rupture of the lower uterine segment, a lot more rare though. And then postpartum, there's risk of subinvolution and sepsis as well. More severe reports of postpartum infection were more commonly reported in the 20th century. There was a study that reviewed 170 pregnancies with prolapse. The fetal mortality from that was 22.1%, and the maternal mortality was 6.3%. And according to one review, the last reported maternal death related to prolapse was due to sepsis, and that was in 1925. So briefly, this is kind of like a culmination of different types of management that I saw in different case reports. So basically, in terms of pelvic organ prolapse in pregnancy, successful pregnancy outcomes require more individualized treatment as there's no set protocol with respect to patient wishes, the gestational age, and the severity of the prolapse, while keeping in mind all the complications that I just went over. The management can vary from a more conservative approach to even surgical treatment and laparoscopic treatment. Conservative management in some reports describes genital hygiene and being mindful of Trendelenburg position to enable prolapse replacement and protect the cervix and help prevent any incidents of preterm labor. I did see a lot of differing opinions with regards to pessary use in this regard. There's a couple of case reports that recommend continual use of a pessary, and that is not to be removed until the onset of labor. There's a couple other reports in other countries, like in India and other Southeastern countries, that say to keep the pessary up until around 18 to 20 weeks when the uterus is large enough to support itself on pelvic rim. When conservative management fails, laparoscopic uterine suspension has been reported to be used. And then just to keep in mind for that, the reports that did use that, there have been some adverse effects. So to only be used when really necessary. And then in terms of the method of delivery, so that should be individualized according to patient preference, how labor is progressing, how the cervix is dilating. We do know vaginal delivery is possible, and C-section is also a valid and safe option if needed. So just to briefly touch on the case that many of you are familiar with, we had a 35-year-old G4P3104 female with a history significant for opiate use disorder, colon cancer, status post-hemicolectomy, and hepatitis C. She originally presented at 33 weeks with complaints to the office with complaints of her insides falling out and severe pelvic discomfort. At that time, her uterus was observed to be hanging outside of her vagina. She had unsuccessful attempts with a cube pessary. Her prolapse was reduced and a Foley was inserted. She then presented a week later for preterm labor. She had a course of betamethasone and was discharged with a recommendation to not use a pessary due to increased risks of infection outweighing the benefits. And she was recommended to be managed conservatively with a brace, but was unfortunately unable to obtain one due to insurance barriers. And then 2 weeks later, she was admitted, and in this admission is when she eventually delivered. So all in all, her delivery was relatively uncomplicated compared to what was expected. She delivered at 36-1, and she was complicated by various lacerations. And of note, her prolapsing cervix was at the level of the introitus at the time of delivery. Postpartum, initially, she was meeting milestones. Later on in the day, she started to feel chills and myalgias, cramping abdominal pain, became febrile to 103. Eventually, she was transferred to the ICU for pressor requirement. She was diagnosed with group A strep bacteremia that was eventually sourced to her uterus based on imaging, and she was diagnosed with postpartum endometritis. Over the next several days, her fevers continued to spike. Eventually, she became afebrile for 24 hours. We worked closely with ID to help manage her antibiotics, and once she was stable for discharge, she would have had a total 12-day antibiotic course. And then future management for this patient was to use a fembrace until she could have a postpartum appointment for evaluation for a new pessary. And then I'm just going to briefly talk about the complications that we saw. So obviously the group A strep endometritis is uniquely seen in this patient in terms of risk factors that she specifically had. So the most important risk factor for postpartum endometritis that we know of is C-section. There's also prolonged rupture of membranes, extended labor, repeated vaginal exams. The risk with vaginal deliveries is reported to be 1 to 3% and can go up to 15 to 20% with unscheduled cesarean sections. And usually postpartum endometritis is polymicrobial. For our patient, so obviously she had a vaginal delivery, still has an increased risk at 2 to 3%, but not nearly as high as C-section. I did find one population-based surveillance study that was surveillance of group A strep infection in pregnancy and postpartum, and found that of the sample, they reported that 85% of group A strep occurred postpartum, with actually the mostly occurring after vaginal delivery within 4 days. Her other risk factors include her history of prolapse, multiparity as well. And then just to briefly touch on what I saw about group A strep endometritis. So most of the literature explains that that has been sourced to transmission from healthcare workers. In the 19th century, it was a more fulminant infection. Now it's a lot more rare. And when it is found, it's usually sourced to a nosocomial or community-acquired infection. Important takeaways that I think from what I saw is that majority of these cases can present within a week. They generally can have a fulminant or mild course. They can present very atypically and can be masked as postpartum pelvic discomfort. And so it's really important to start prophylactic antibiotics when it is suspected. And then finally, these are just some future directions that I thought were interesting or that I couldn't find as much information on in the literature so far. So variability by ethnicity with regards to, like I said, prolapse being more common in white and Hispanic women in pregnancy compared to women of African or Asian descent. I'm very interested in global public health and would want to explore why developed countries specifically have higher rates. Surgical management options I didn't touch on too much in the limited data that I found, but I want to look more into that. Again, like I said, the group A strep endometritis, how that was sourced, and then specifically in our patient, how that was to be determined, and then rates of relapse for both pre-existing and acute onset prolapse. And then finally, how modes of delivery can affect postpartum complications. These are my references. And I just wanted to say thank you to Dr. Baxter, who was on service for a majority of this case and did a lot of related teaching and gave a lot of advice. And thank you all for listening.
Hey, Vaishali, great job. I was wondering if you had come across some of the literature on management of the labor in these patients. specifically with regard to vaginal packing. We did vaginal packing for this patient to allow pressure on the cervix to help the head be applied to the cervix for the labor process. Jen and I had sent around a few articles mentioning the use of magnesium soaked gauze if the cervix was swollen and you were having a hard time reducing it. Hers was already reduced, so we used that. I was just wondering if you had seen other recommendations for labor management.
Yeah, so actually here I'll pull up on, there was 2 studies that explained the use of vaginal packing and advised that I saw. One was in India. And yeah, both of them, I think like Jen also sent a report that advised the use of that as well. So definitely exists, just like very limited literature that describes most of the protocols or recommendations that I saw were very patient-based and specifically with regards to the specific patients that they saw.
Yeah, and for a Paris patient who was already 3 centimeters dilated, I did feel that her labor course was longer than I expected, which kind of goes along with her history. In terms of, it's funny, I never met this patient, but I was on call all week when she was being induced and then when she developed group A strep sepsis, so I feel like I know her very well. She did present very classically with the very abrupt onset of hypotension and needing to be transferred to the intensive care unit overnight. And thankfully she was on, we did triple antibiotics because she was so high risk for endometritis and a variety of organisms that were potential. She was someone that I was very worried about because her cervix had been exposed for months. So, but she definitely had the classic presentation of rapid decompensation.
And interesting, as Vaishali pointed out and Becca pointed out, very rare for us to have postpartum endometritis or infection afterwards after vaginal deliveries. But certainly, as you guys pointed out, the risk factors that may be approximate what that increased risk is with that, having a cesarean in labor with their prolapsed uterus. Certainly appreciate people's refresher about Semmelweis and peripartum, childbirth fever and group A strep. Unfortunately, when we get these reminders, it is, as Becca pointed out, pretty scary. Not only the rapid onset of the hypotension, but also the high temp, how high it is. Certainly glad to see excellent care and prevention of mortality, frankly. It sounds like Rupsha was about to comment.
Oh, sorry. No, I jumped back on. I unfortunately missed the presentation, so the patient.
We have 6 more minutes. Vaishali, you did an amazing presentation. Thank you for teaching us. That's great. 6 more minutes for Dr. Sorrentino. She has a case that she would like our input on. Miriam?
Oh, yes. Hi. Thanks, Huda. So I'm involved in the care of this young girl. She's in her 20s.